So hello, everybody. My name is Chris van Vlitsing, and today I have the great honor to chair a session on growth for your LAAC programs. With me is an international faculty with Dr. Gens from Magdeburg in Germany, Professor Riafol from Lyon, and Dr. Salinas from the Clínico San Carlos. We'll each have short slides lasting for 15 minutes. If you do have any questions in between, please feel free to pose them. And in the end, we'll pose some poll questions, and yeah, we'll be really interested in your feedback and your questions. So I'm going to start, and I'm the only non-clinician talking today from the dark side of power. On the topic why we decided to grow the LAAC program in our hospitals. And at first, we thought, or we think that we really believe in the clinical relevance of occluders, and we're all undergoing dramatic changes in healthcare provision. We do have all a lack of qualified staff, so we thought that it would be great to identify the patients digitally. We didn't only want to identify the patients within the hospital, but also in outpatient care. And for my region in the German East, we wanted to lead the way within the SANA group. And also, as future lies in cooperation, we wanted to redefine a partnership between Boston and us. And we started a great journey. So what did we do? We started within Berlin-Lichtenberg. It's a 650-bed hospital in the east of the capital, with a 100-bed cardiology department, 3 catheter labs, and where we do have a great experience in implanting occluders. We used the ClearPath system from Boston to identify patients not only from the cardiology department, but also from other departments. ClearPath is a software system based on certain scores to identify patients possibly eligible for occluders. And we didn't only keep on screening patients within that hospital, but we also thought of acquiring referring hospitals. So we went to neighboring hospitals in Königs Wusterhausen and Lübben, also belonging to the SANA group. And we also implemented the algorithm from ClearPath within the software system of the hospital. And though we do not implant the occluders there, we do have the option to identify the patients eligible for occluders there, which are then referred to Lichtenberg. And the third step was to include our outpatient departments. We have around 80 practices in and around Berlin, and we also flagged the patients there. So we used the system not only to look at the cohorts within one hospital where we implant, but also to analyze the data of referring hospitals and the outpatient departments. It was quite a complex, or it is quite a complex project. There are many people involved. We have our head physicians, we have the implanters, we've got the screening physicians, we have the management, the IT, the controlling, and the purchasing department. And it's not that easy to align everybody, but we had a great support from Boston to move in the right direction. And we can say right now that with that approach of intensified flagging and integrating referring hospitals and outpatient departments, we're able to augment the number of patients. So we started with 28 implantations in 21, and we were able to raise, we redesigned the project at the end of the year 21, and you can see that we really raised the number of patients. Now in 22, we've got a growth rate of about 50%. And with every patient that gets an occluder, the focus of clinicians and GPs rises. And we can also use the data from the patients who already got an occluder to improve the algorithms. As I said, we had a great support by Boston. We learned how to shape corporations in the digital age, and we can really say that it paid offer us. Though there's still a lot to do, I have to say. We have to facilitate the workflow to gain further acceptance. The ClearPath is a system which is not automatically integrated within the hospital's software environment, and it's always better to integrate the algorithms within the software that the clinicians use on a daily basis. So integration is one major thing to do. Second thing is that we really do need to improve the KPI reporting. I mean, there are 4 major indicators. That's the number of patients to screen, the number of patients screened, the number of patients eligible for the occluder, and the number of implantations. And we do not get these KPIs combined on a regular basis, but I think it would really help for every department to get this. We need to enhance the algorithms. We'll have a poll question on that later on, but still, from the patient that we look at, we only get a fraction of patients who actually implant the occluders. So it would be great to have a more efficient algorithm to spare some work. We need to discuss with Boston the license models for the ClearPath, especially when we will set up further clusters for ZANA. That's my part so far. And then I'd like to introduce our next speaker, which is Dr. Gens from Magdeburg.
All right. My name is Konrad Gens, and I'm working in the University Hospital in Magdeburg, and I would like to present you the journey of one patient who has been identified by this digital patient identification system. I think we are all convinced about the usefulness of the left atrial appendage occlusion, but we also all know how hard it is to find patients who are eligible for left atrial appendage occlusion. And this program might be one help to find more patients which can be implanted. And I've also helped to develop this project, and I will just start with the clinical history of one patient. And here you can see already printed in bold letters the information that the ClearPath tool can already tell you. So we have an 83-year-old lady which has been hospitalized with anemia and epigastric pain, and she went to the gastroenterology ward. As side diagnosis, she has a permanent atrial fibrillation, and she has been treated with a NOAC with rivaroxaban. In her history, she did suffer a stroke in 2017, and she was also implanted with a TAVI a couple of years ago. The lady has a coronary 2 vessel disease, and she already had a myocardial infarction in her history, and she also has a peripheral artery disease. Her risk factors are arterial hypertension and diabetes and obesity. And she's also suffering a chronic renal impairment. In the diagnostic findings, we couldn't find any signs of a low GI bleeding, but we saw an excessive erosive hemorrhagic and gastritis and duodenitis, but an intervention was not possible. So how do we go on from here? We could probably just restart NOAC after a couple of PPI therapy, but we have to keep in mind that we didn't have any obvious cause for the gastritis, so restarting NOAC would not probably be the best idea. And because there was quite a low awareness of other colleagues of the left atrial appendage closure as a feasible option for those patients, we would probably it would not make sense to wait from a call from a colleague from a different department asking for help. So hiring a spy would be a different option, but I think this is the optimal tool. We have the optimal tool, the Advantix ClearPath tool. And so how does it work? How can we get this patient? It's quite easy. The tool sends you an email to the screening physicians who have been assigned before, and this tool will tell you, okay, it has found a new patient, and you can just click on the patient link, and then you will be in the patient information page of this tool. And here you can see, it's in German, I'm sorry, but you can see the sex of the patient, the age, you can see the ward in which it has been hospitalized. This is the clinic for gastroenterology. And you can also see as one major information, the priority. And this patient is priority number A, which means that she has a main bleeding as a main diagnosis and has atrial fibrillation as a second diagnosis. And this is also coded here as Hauptdiagnose and Nebendiagnose. And if you click with your mouse on the eye, you can find even more what this says. So we have all the different diagnoses I have mentioned in the slide before. The tool already tells us that this patient has this diagnosis. What you can also see is the patient or the date when the patient was hospitalized, and you can already see the CHEST-VAR score, and you can calculate the Hess-Bled score by yourself if you would like to. And having those information, you can basically start screening. And when I do this, I usually copy the case number into our clinical information system. You have to keep in mind that the flagging tool, the ClearPass tool, is a web-based interface, so it is not integrated into the clinical information system yet. So we just copy it and put it into the clinical information system. The first thing then, what I do then is I check all the information, all the inclusion and exclusion criteria, and which is very important is, does the patient have any reason for prolonged or for oral anticoagulation out of a different reason other than atrial fibrillation? Are there recurrent thromboembolic events? And does the patient have deep vein thrombosis? Does he have mechanical heart valves other than this? So this would exclude the patient from being implanted with the left atrial appendage occlusion. After this, I usually try to get an overall idea or impression of the patient. How is the patient? Because I want to exclude patients which are like in a permanent vegetative state, who have a palliative malignancy, or who have otherwise a low life expectancy, so which you would not really want to implant. If I excluded this, then I will review all the existing diagnostic findings and try to see if there are pre-existing doctor's letters or if there are chest X-ray pictures, so I can get a whole picture of the patient that I would like to implant. If I didn't find any exclusion criteria, then I will try to contact the patient, and how I can do this, the tool also tells you this, because the tool knows if the patient is still in hospital or if he is already dismissed at home. So if the patient is still in hospital, I try to contact the treating physician at first and try to tell him that I have a good idea, a good solution for the problem of a bleeding patient on oral anticoagulation. And if he says, well, yeah, that's a good idea, then I will go to the patient and show him this feasible option. If the patient has already been dismissed at home, I will call him and tell him at the phone that we have a very nice solution for him. And I don't extend this phone call too long. I just ask them if I can invite them in our outpatient clinic so that we can talk about this option. And if the patient doesn't need further information, we can also directly make an appointment for the procedure. And this is displayed in the patient course down here, starting from to contact the patient, going over, make an appointment in the outpatient clinic, making a date for like preceding diagnostics, having the implant procedure, and the procedure has already been done. So this is the journey the patient has to do. And in this case, the patient was still hospitalized. She didn't have any other questions. So we just made an appointment for the procedure date. And yeah. If you have more than just one patient, if you have a couple of patients screened, then you tend to lose the overview. So the program is also capable of keeping an overview for a certain period of time. And there are several buckets which are shown up here. Like for patients you still have to contact, for patients you still have to make an outpatient clinic appointment, or which are patients which are waiting for their outpatient clinic appointment. We have a bucket for making the procedure date and for having the procedure already done. So you can, it's easier to keep an overview of all the patients you have flagged and identified as possible candidates for left atrial appendage occlusion. And then I was asked to give a short overview of the implant procedure. I think everyone does it probably a little different. At our hospital, we do it like the following. At first, we do a visualization, a 3-dimensional and 2-dimensional visualization of the left atrial appendage. And then, of course, we do a measurement of the landmarks. And then we decide which occluder size we would like to implant. And here we have the biggest diameter of this oval thing of about 2.8 centimeters. So we decided to implant a Watchman Flex 31 millimeter. We proceed with an LAA angiography over a pigtail catheter, and then can also advance the sheath over the pigtail catheter into the left atrial appendage. So we can safely get into it. We also do a Cineshoot to exclude air bubbles, which we might push up while we push the device up through the sheath. We do it TE guided, so we can see that we are securely in the left atrial appendage with the sheath. After the device deployment, we then do a tag test to make sure that it stays in place if you push on it. And then we also do a dye injection to make sure that we have covered all lobes. I have to say I'm a little sorry for the low quality pictures, but we try to use as low radiation as possible. We only use 3 frames per second and have the very lowest radiation exposure. So we get the exposure as low as possible. If the device is employed, then we just check for the device position, we check the compression, and we check for possible gaps. And we see the device here probably sitting nice in its place. We measure the shoulder and the compression is just over 20%, which is perfect, and we have no peri-device leakage. So afterwards, our standard procedure is still setting the patient on a dual antiplatelet therapy with us and clopidogrel for 3 months. And if the TOE at 3 months does not show any device-related thrombi, then we reduce this scheme to us as monotherapy. In this patient with the gastritis and duodenitis, which with no obvious cause, we were a little reluctant to give this patient aspirin. So we decided to switch from rivaroxaban in full dose to low dose apixaban, which the substance itself is not associated with that much gastrointestinal bleeding. So we think for this patient, this is probably the best solution. Which barriers did we encounter? Which barriers did we have in mind? Well, at first it's quite a technical, or it's quite a barrier to get the legal requirements for access to pseudonymized data for a company which is even not even a German company, so an international company. This needs quite some convincing words, or our legal department needed quite some convincing words and convincing papers to get this done. And then you also had to organize the interplay of the different IT sub-departments to get all the technical stuff done. And then at the beginning, we did have quite a huge number of flagged patients, which ended up as being a high workload with only low output. But with refining the flagging criteria and with an active case-related feedback, we could lower the number of patients flagged and raise the index of patients which actually are suitable for left atrial appendage occlusion. We didn't receive or encounter any rejection through the colleagues of other medical departments, so they actually were happy if we could give them a different solution for the patient. And one barrier, I see that it's a little embarrassing, but we still don't have a digital patient file system yet, because if you had something like this, maybe it would be more easy to exclude patients who have a high nursing score or something like this. And the other thing, which was already talked about just before, is that it is still a different tool. Like, you have to open it up in your web browser. It's not integrated in your clinical information system. So this would be one thing that can be worked on. So in summary, I can say that the patient identification can be challenging for left atrial appendage occlusion, and the low awareness of treating physicians is one obstacle. And so this can be, or the ClearPath tool can help to overcome this obstacle. And it's an easy and secure way of identifying patients which are suitable for left atrial appendage occlusion. And so with this tool, I'm pretty sure that we can expand the number of an economically attractive procedure and give the patients a different option without anticoagulants lifelong. Thank you very much.
So Dr. Gens, thanks a lot for your interesting slides. I've read here in the audience Q&A that someone says, I've seen this situation many times in my hospital, really look for solutions. So you just picked the right patient for the audience. That was a great example. And also what you said about refining the flagging criteria is really important from my point of view, because we've had the same thing, that for some departments, the predefined algorithms didn't work very well, and we got too many consultations in the beginnings. And I think it would be great for the bigger centers participating in the program to share their data or share their experience, what the best ways of refining the algorithms are. Because I think we can only get better in the ratio of patients to screen to implantations. Right now, it can still get better. And as we have no more audience Q&A, I'd like to come to the related poll question, if possible. And I'm going to read this out. And I'd like the audience then to participate with the live poll. The question is this the typical patient etiology that you traditionally see in your centers? And it's quite easy. You can answer yes or no. And if many of you vote for no, it would be great to know what your patients are like. So the overall result, as I can see it, is that of the participating clinicians say that those are the patients that they usually see with that indication. So Dr. Gens, it was exactly the right patient to present. I can really only say yes. In our hospital, it's the same. We get many patients from the gastroenterology department. They have massive intestinal bleedings when we get to see them. So raising the awareness within those departments, I think, is a great first step. And for those who voted no, the 11%, please feel free to write into the Q&A today how your patients differ. And I would suggest that we proceed to the next presentation. It's Professor Riofol from Lyon, one of the most renowned French centers. And Professor Riofol, we are really keen now to hear your presentation.
So thank you for inviting me. And in fact, it's my testimony of how Adventix helped Lyon in France to engage with the left appendage closure program. So to remember, Lyon is in southeast of France. And what's important to remember that in France, we have a very strict criteria for reimbursement from the health ministry. We need Schwarzwald score above or equal to 4 and a definitive contraindication for anticoagulation. So it's quite restrictive in comparison perhaps with Germany. So when we began in 2013, it was a difficult start. And you have the number of cases performed per year, and the increase is quite low. And in 5 years later, we performed only 40 cases per year. So it was much below what we expected and much below what the population in Lyon and in Rhône-Alpes, the area need. So in 2017, I had the opportunity to embark with Adventix program. And it was a great opportunity for me and for my department. The first step was to understand barriers that exist in development of appendage closure. And we observe a lack of knowledge for physicians. And it's quite a paradigm shift in France also, to stop anticoagulants, to move to an invasive procedure. And in the first years of the appendage closure, there was fear for complication, because I observed that colleagues often prefer not to give anticoagulant and not to do nothing for a high-risk patient. And if a stroke occurred, that's fatality in a way. But they were reluctant to decide an invasive procedure with small but potential risk of, of iatrogenesis. So lack of knowledge from physicians, lack of knowledge from patients. No patient at all know that at that time what an appendage was and how we can close it, and why it is important for them, because they could stop their anticoagulant. So we were convinced that we need to talk and to discuss and to increase the knowledge of the global population. Our patient referral in 2017 was very basic. That was mostly a coffee talk with colleagues and nothing more like that. The patient pathway was unclear, with some call to my colleagues, some calls to my secretary, some calls to me, but nothing was very clear and regular. And last but not least, in Lyon, there is a fierce local in Lyon and regional in Rhône-Alpes area competition with other hospital and for many clinics. So that was the points we observed that could slow the development of appendage closure in Hospice Civil de Lyon. Next. So with Adventix, after this first inventory, we discussed a lot with the team, and the three main points were identified. First, how to better identify patients. So, as it was just discussed in the previous talk, we discussed about automatization of the identification of patients, but we can discuss this point in France. It's quite difficult, and colleagues are very sensitive if I just have a call to them and say, "Oh, your patient that could benefit an appendage closure." It's sometimes contra positive for the patient. The second big question was how to promote the therapy. So we work a lot on educational materials for physicians, educational material for patients, and we build up a structured program of communication with medical referral. And the third question was how to optimize the management of procedure. And thanks to the Adventix team, some performance indicators were built up and helped me to progress and to go step after step. In terms of publicizing the procedure, we take advantage of the 100th left appendage closure in Lyon to have some discussions with the local journals for patients. I don't know if I can advance. Okay, so there is some interview for the public, and I also do a conference for the patients associations, stroke patients associations. We build up a flyer for patients explaining how the appendage closure is performed, why it is performed, why it's proposed for them, and the potential risk and the potential benefits. And thanks to the team too, we run a small film available on the hospital site and on YouTube too, explaining how it occurred and how we can perform it. So that was the patient's part of explanation. What we've done then to the colleagues, we decided to discuss and to explain specialties after specialties. And in 1 year, we had 7 sessions to colleagues with a quite huge number of colleagues in my institutions. We sent a flyer to the GP explaining the benefit of the left appendage closure in comparison with no treatment at all or the hemorrhage risk for the patient. And I encounter geriatrician, anesthesiologist, neurologist, nephrologist, GP, gastroenterologist, and cardiologist to explain how it works, how evidence-based shows the benefit of the appendage closure, and so and so. I attended some regional and national congress for general practitioners and geriatricians to explain, because many of them, even after 4 or 5 years of experience, they even don't know what left appendage closure is. We build up a flyer dedicated to physicians with a reminder of the Schatzvask, of the HS blade, and the procedures, and of course the contacts, simple contact to have a call for special patient. And the next step was to simplify as much as possible the left appendage closure procedure. And we embark in mini TE to do the procedures. That means that with this mini TE, that's only local anesthesia. I didn't need anesthesiologist anymore. And during the pandemics, that was very important because we could continue the program without any stop because of the lack of anesthesiologists. So there was a huge effort to develop mini TE and as simple as possible left appendage closure. On top of that, and that's the credit of the Advantix teams, they collect all the tasks my secretary done for a patient before procedure, and they add all the minutes that was dedicated for a case. And at the end of the day, it was clear for my administration that I need an extra secretary. That's real. It was incredible for me, but that's real, and it was very, very important for me, and it's very very important. So what are the results of these efforts? In 2018, around 50 referring physicians were part of the program. More than half of them were cardiologists, geriatric was around 20%, neurologists 15%. And 3 years later, that means 3 years after the beginning of the Advantix program, now I can count more than 80 referring physicians, and the proportion of specialties has very modified, with less cardiologists, more geriatrics, GP, gastroenterologist, and always neurologist, and even pneumology. So with Advantix, I could have widened the scope of referring physician in a big fashion. And this is very simple curves I get from the Advantix team, which collects the referred patients months after months. And you have here the year 2018, that's the first year of Advantix, 2019, the second year of Advantix, and there is no big increase. There is the same evolution. However, the year after, 2020, you have the gray line that is above, and this is the result I obtained last year with 2021. So, in other words, on a rolling year, here is the evolution of the referred patients. And with the arrow, you have the beginning of the Advantix program. And that is what I can observe. First year, quite nothing appeared. There is some delay, I think, before all the efforts get back. Then there is a first step for the second year. And now that means since 1 year, there is a big slope. And I think it's important, that's how I interpret this, this evolution. In France also, we need some time to convince colleagues to refer patients for left appendage closure. It's part of knowledge, it's part of trust in the team, and that's how it occurred in Lyon. And more than that, with the program, I could observe that the rate of conversion, that means the proportion of patients that I visit or who came in my consultation, and that effectively had the procedure. In 2019, it was less than 50%, and now it's around 70%. So the quality of referring is better now. And in terms of implantation, here you have the total evolution in Lyon from 2013 to the beginning of Advantix and now. And I'm not a statistician, but I think there is a modification in the slope. And this triangle is probably what I can reasonably observe with the Advantix program. So that's huge. That's huge. And now in Lyon, we probably be above 100 procedure in 2022. And with the Advantix program, we have some criteria we could follow during time. That's at the beginning, where we were on the objective, and year 2, now we're year 3. Here are the progress. So that's factual, but with Advantix, I enjoy more patients, more accurate patient for left appendage closure, and more procedure in my center. And now for me, the next steps are to be prepared for the increase in left appendage closure procedure, because in the next year, there will be a big increase if closure could be non-inferior to oral anticoagulation. The second step is to increase the number of senior physicians in my lab and my institution able to implant. And the next move for me is to increase the formation of colleagues from nearby centers around Lyon that could refer patients and come with me in the lab to implant procedure for their own patients. Thank you very much.
So, Professor Rieufol, thanks for the great talk. I'm amazed by the story of the Advantix secretary. I can imagine that many of the listening head physicians have recorded this to be on the doorsteps of their managers tomorrow. But it shows nicely that we really need an intensive communication with patients and doctors, and that you need someone specialized who really knows the needs of patients, the needs of doctors. And I think such a human platform like a secretary is a great form of organization for that. So I'm impressed. That was a great talk. And let's proceed to the related poll question. It is, do you think those areas of improvement are pertinent for an LAAC program to improve? The areas of improvement, just to say that, are the identification of patients, promotion of therapy, and the optimization of the management of procedures. And the poll should be open now. yes, the number is rising, but we would still be happy to get more answers. So I think we can close the polls. I mean, I'm working in Eastern Germany, so I'm quite used to socialist election polls, but we've reached 100% agreement on that question. So those are the right steps, together with Boston, Professor Riofol. Thanks a lot. And let's now proceed to Spain, to Dr. Salinas, who has been able to achieve an impressive progress without using that much tools as we did this in Germany and France. So, Dr. Salinas, your talk. Let's go.
Thank you, Christian. So, I'm Pablo Salinas from Hospital Clínico San Carlos in Spain, and I would like you to think a little bit on this problem. So, I think these are the problems that LAA occlusion face. So first thing is that cardiology usually is going to start anticoagulation, but problems will go elsewhere. For example, gastroenterology or wherever the bleeding will appear. Second, the patients are not going to come spontaneously. This is not taboo that everyone is going to look for interventional cardiologist. So you really need to go out and find them. The third one is that under-penetration of this therapy is the rule. So many patients and doctors are unaware of LAA occlusion, and I think it's our role to go out there and present this therapy. The fourth item is that I believe that a true multidisciplinary approach is key to managing these patients. So discussions can be done solely on cardiology, but it will be much more profitable if you involve people from internal medicine, hematology, maybe geriatrics medicine. And finally, we must understand that this is a preventive procedure. So a preventive procedure needs a very low rate of complications, ideally under 1%. For this, what you need is a very good program with high volume. So if you are doing at least one LAA occlusion session per month, you will keep your hands trained and probably your complications will go down. So it is very difficult to know how many implants should be done in a specific country, but this is an approach that Boston made, and these are the numbers. So the penetration of the therapy in general in European Union comes from 0.2% to 6.4% of potentially treatable patients. And this is different from Spain, 2%, to Germany, for example, 6.4%. So this is highly variable. And this is a number that maybe it's difficult to understand, but I think there's a number that makes sense, and it's something that you should be doing at least 100 procedures per year per million population. And I think this is a number that it's a little bit more understandable, and you can tailor this to your referral area. So let me tell you my story. This is my hospital. It's in the central area of Spain, just the capital city, where we have many hospitals with cath labs, over 15 public hospitals with cath lab, too much probably. What we did is that we put the cath labs in the referral hospitals, and we send the doctor. So I go sometimes to a referral hospital and I do the cath, the daily workload there. And the structural heart disease and more complex cases are coming to the mother hospital, which is Clínico San Carlos. And 4 years ago, we built an administrative sign on this, and we call this CardioRed, which is CardioNet. And these are 4 hospitals that covers 1 million population. So this is my network, and this is the program. The program is called Cardiac Intervention for Stroke Prevention, and it involves PFO occlusion and also LAA occlusion. And this is the human team. We are interventional cardiologists, but we work very closely with neurologists in the stroke unit, with CP, with the cardiac imaging. Obviously, we have very good trust with hematology guys, anticoagulation unit, and internal medicine and VTE team. And the facilities obviously are needed. We have 3 interventional cardiology suites. We have 1 weekly dedicated clinic, and you have to have also strong facilities, because if your program is going to grow, you will have to be able to do this in a timely manner. This was the program before I got involved in this, and this was an open program. It was working, but you can see the numbers, the early numbers were below 20. And what happened here is that we got the signature of this program where the referral was much easier between these 4 hospitals, and we also went to the hospitals to do the procedure, so we get more in touch with the local doctors there. And also we got more people involved, and we try to rethink this program. And the result of this rethinking is that numbers are increasing by 20% per year. So we are now doing 50 procedures per year and growing. So I think this was a success. And I will just present here just a few actions, very specific, that you can maybe think on doing. So first thing is make the referral easy. So you have to remove barriers. Rather than asking people to send the patients to anesthesiology to get a cardiac imaging, I just give them my phone. So most of the doctors will have just my personal cell phone, and they will contact me, or maybe you have your secretary phone, or maybe you contact them by email. But my advice is that you just need a clinical record number, and you will do the rest. Some people work better with referral sheets. You can do this, and some people will work better with paperwork. Whatever it is, but make the referral very easy. Second thing is to give lectures. Obviously, everyone is doing this, and I like to show them the device. Actually, I show them the Watchman is a very an offensive device if you have it in your hands, and you can show it also to your patients and show how the procedure is being done. This is very standard. And another thing that I like doing is just to go to different hospital meetings. For example, there is a hematology and VT meeting where I took this. This was a post-surgical patient that had a very large leak in the surgical closure of the LAA. Probably I could have managed with this patient by myself, but if you take the opportunity to discuss this with other people and get them involved, they will get interested in the therapy, and you will also know them by face, and probably it will promote your referrals. The fourth thing is promote educative events, and probably it's more about clinical events rather than interventional ones, which are obviously fine, but probably most interventional cardiologists will be on your side, but maybe some clinicians don't. So what we did was, for example, we did several meetings, but one very interesting was difficult decisions on anticoagulation. And it was all about bringing clinicians with their own problems. So for example, I asked the hepatology guys to come by and speak about those patients where anticoagulation is a pain, it's very difficult, neurosurgeons, neurologists, gastroenterologists, and just talk about which problems do you believe, which patients do you believe are very difficult to anticoagulate. And then you just give your talk about the LAA occlusion, and it is very obvious that they will be very open to send them, rather than being very aggressive and send me the patients. But they will see the problems and face them, and probably this was very useful for us. So maybe you can try this. And this keeps going around thrombosis and PFO, and also direct oral anticoagulants and oncology, for example. It is a very good target, and also gastroenterology, because gastrointestinal bleeding is still a very big problem with direct oral anticoagulants. And finally, you have to go public, and I think the French colleagues show a lot of actions regarding this. And we, for example, went to a local health newspaper. We also like to send notes to the website of the hospital when we did our 100 procedure, 200 procedure, and so on. And from time to time, we just show the numbers and the low rate of complications. And finally, if you stimulate a multidisciplinary research and you involve other doctors, this is, for example, a recent publication from the team, you will engage them in a very interesting manner from the scientific point of view, and they will obviously, as a side effect, probably send you more patients. So this was the shift in our program, and this was before 2018, only or less than 25% of the patients were coming from outside cardiology, and now we are over 40, and this is probably a little bit biased because some referral hospitals just canalize the patient through cardiology, but this is what you really want to see to increase your non-cardiology referrals. And this is a picture of the potential sources of patients. You can think that this is just one hospital, so reaching out all these areas is very difficult. And if you have 4 referral hospitals, this becomes really, really very difficult. So one thing that Boston facilitated was the Therapy Awareness Rep program. And this is only working in 2 countries in Europe, but maybe your country can be the next one. And in a very brief way, I will just tell you that this is something like a pharma rep that will just go and reach these areas that you target, and they will just speak about the therapy. It is interesting that it might leverage educational programs and resources, and it will promote a multidisciplinary approach. And also, I think it can enhance reference engagement through just routine visits and recurrent follow-up. So, for example, this rep just opened some doors that were closed to us, just because we were not thinking of probably going to this 3rd hospital dialysis unit. And one thing that is very interesting is that you can tailor it to your needs. So, for example, I gave him just two very important rules. One was to speak about the therapy. Don't really speak about this device or the other device. Just speak about the therapy and about the problems of anticoagulation, and that there is a solution and they can contact us. And the second one was that doctors still are the key, the center of the interaction. So we keep all the talks are being given by doctors, by me or my colleagues, and all the contacts will be doctor to doctor. So they will just know patient information. They just remind and open doors for you and reach out places that probably are a little bit far for you to just go and give a talk. And this is an investment. So we just started this like 9 months or maybe 12 months ago. And now we are seeing an increase in referrals from very new places. And this is interesting. And I think with more and more years, we will have more return from this program. This is our actual picture. We have 1 out of 4 patients coming out from our mother hospital, and 45% of the patients coming from other places rather than cardiology. Most frequent places, internal medicine, and second is neurology. So what are the future directions? So I think we could be reaching 100 cases per year in 4 to 5 years. I think we need to do some work on streamlining the pre-procedural testing and close the gap of the timing of these procedures to just being able, my target is being able to have the appendage closed just 1 month after the referral. And we really want to reach primary care. This is going to be difficult because there is in our area 43 primary care centers, but this is where the oral anticoagulation clinics are. And I think this is a target that we have to face. And I was very happy to see that the French colleague is also contacting this area. We still work in strengthening the multidisciplinary network, and we will obviously keep up with educational events because involving people in this is having a very good return in terms of referrals. And this is a final picture just to show how are the numbers. So probably if you take the total AF population over 65 years, there's something like 8 million people in Europe. And if you take non-valvular and high risk for stroke, you get 5 million people that will need anticoagulation. And it is approximately 10% of people that will have relative or absolute contraindications, and the other 90% will be probably tolerant. I think this could be even less, probably 85, if you take direct oral anticoagulant trials. So this would be potentially eligible patients for LA occlusion. I think we are very far from 10%. So the message is that the room for improvement is huge. And just to end, how to face the problems of finding the patients, of challenging this under-penetration of LA occlusion, and how to get really multidisciplinary approach. So just 3 very easy messages: expand your network, remove barriers for referral, and provide feedback to your doctors. I think they will appreciate that. And that was everything. Thank you very much. I will take your questions, if any.
Thank you, Dr. Stillens, for the great talk. I mean, it shows, also shows how important it is to expand your network to referring hospitals and outpatient care, how important it is to work with the other disciplines in the hospital. We've talked about the gastroenterologists and the neurologists so far. And I really like your pragmatic approach, because as far as I know, you didn't have the Advantic solution in the sense of flagging the patients. You just did it, which is a great case. So not everyone has to wait for a great Boston solution. What I learned from your slides is you can start today. If you're a great cardiologist and if you're keen on communication like you can start today. So let's proceed to the related poll question. Do you think that this future vision for the LAAO team is comprehensive enough? You've got the possibility to answer with yes and no. And what do we mean with the LAAO team? We think that this should include the cardiologists, the gastroenterologists, the neurologists, and other clinical departments. So is multidisciplinarity important for the success? Please vote yes or no.
Yes, maybe does anyone have any other proposal or areas where they found patients? For example, we found lately a lot of patients in dialysis areas, for example. I don't know, which is your key to success? Where is, because gastrointestinal bleeding is very common, but there are some hidden areas. I don't know what you think about this.
Well, we've seen, we got in German something called geriatrics, meaning it's a general treatment of older patients who do not have clear clinical symptoms or are not treated interventionally. But we find that because they're often treated in outpatient departments by general physicians, that they do not know the options of an occluder. So we do see quite a large cohort of old patients from our geriatric department too.
That is interesting, obviously. And the prevalence of AF there will be very high, I guess.
Correct. And I think, what we also learned from Professor Riofol, that it's really important to look at outpatient care, because we started looking within our hospitals at first. And then we saw that we can really raise the numbers with patients from GPs and other doctors in outpatient care. Professor Riofol, you could comment on that, but do you have a ratio of how many patients you get from other hospitals and how many you get from outpatient doctors?
Actually, my hospital is close to a neurologic hospital. So the first step was referral from neurologists and from some cardiologic colleagues convinced of the procedure. And with quite good results and good communications, it expands. And now half of the referral patients came from outside.
And Dr. Gens, are you already in contact? We've seen your example from the gastroenterology, but what are your findings?
Unmute. Well, I think most patients we implant are found in the gastroenterology department. This is probably more than 50%, I would guess. So I was a little astonished. you other guys did not find that many patients in those clinics. This is our major finding. One more thing that we do is we're just in the process of building a relationship to what is it in English? To clinics which are like the neurology recovery departments, where patients after stroke go to for having their tactile features getting back into normal. We go to those clinics and hold speeches, tell them about the solution we have, we can offer them. And there are a lot of patients which intracerebral bleedings which might profit from left atrial appendage occlusion. So I think this would be another option.
I guess you're right, because many patients get NOACs to prevent them from getting a stroke. So patients related to neurology or to rehabilitation in that sector are probably quite often eligible for such a treatment. Does that answer your question, Dr. Salinas?
Yes, sure. I think we just from time to time reach out some area, and you just get surprised that they will receive you with open arms. So from time to time, I think it's 3 or 4 years, maybe you have to restart a little bit your program and go to somewhere else in your hospital, and you might become surprised. That's where this therapy rep program is really boosting us up, because it really goes some places that sometimes you just don't get time to go, or just don't think it's really interesting. So it is something that I think helps.
What I find interesting is that we even had patients directly asking for the treatment while seeing it on TV or reading the newspapers.
Yes.
Because you have these patients who bleed, and who bleed often, who do not get good treatment within the outpatient sector. So what I find interesting is that sometimes we even had a direct patient interest.
In Spain, it's rare. You cannot advertise on a specific therapy, but you can go in just a divulgative manner. So that's what I meant by going public. So you have to reach out further than your hospital. And now everything is in internet and social networks. And I think the French colleague also showed us how they made a YouTube video, and eventually the patients reach out to these things, because the first thing they do when they have a problem is to Google the problem. So eventually, if you come out somewhere, maybe they will reach you out. Yes, why not?
And looking at the poll, we get the clear response that the future is multidisciplinary. I mean, that's not something that many clinicians have grown up with, but I guess the younger generation of doctors is more open to such approaches. So I think this is the right approach that you showed. The second poll question is in regards to the potential of LAAC patients. I mean, Dr. Salinas, you said that coming from 50, you would want to reach about 100 patients a year. And I think that is something that other hospitals could reach to translate it a little for those not working with the Advantix algorithm. Basically, look at the patients that you have in your hospital with the CHADS-VESC score equal or greater than 2. And taking that into consideration, the poll question is, do you agree with this outline of potential LAAC patients? Would you see a number between 50 and 100, as you've seen from Lyon, Spain, and the German hospitals?
I think it's even bigger. I mean, this number that the Boston guys came out with was 10%, but I think it's even bigger of just ChatBask over 2. I think it's more like 15% maybe in training. But 10% is a very nice target.
So we see that about 70% of those taking part in the polling question here agree. I'm on your side, Dr. Salinas. I think the potential is even greater. What all people today, or all members of the faculty, said that the knowledge of therapy isn't given that much. So I think your approach to really have a representative who has a clear-cut program to raise attention for the program would help. Because I think we all here in the faculty think that the potential is greater than the numbers that we have today. Professor Riafol, you extrapolated the numbers, and I'm also on your side. I think the more attention we get, the more the numbers will rise, because we've got so many patients treated with LAAC and with that ChatBask, or as Dr. Salinas said, that my prophecy would be that if we'd have the same session in another 10 years, we wouldn't talk about 100, but about maybe 500 patients per center. Do you agree?
Sorry,
I totally agree with you. We are very we have a slow rate of inclusion in the program, but the more the awareness will increase, the more the patients will arrive, and the more the evidence-based data arrives with LAAC especially, and that thing that will be a big step when, for example, Champion AF the result of Champion AF will arrive. I think that will be a big change for the clinicians and for patients.
Dr. Gens, perspective from Magdeburg?
Yeah, I think the perspective is that not only bleeding patients will be included in the future, but I think it will be, or it will develop to a real alternative for all patients with atrial fibrillation and the need for anticoagulation. And maybe it should not only be like all anticoagulation on the one side and left atrial appendage occlusion on the other side. If we look at the data from the LAAC 3 trial, I think it is, there we have both arms combined. So why not implant a left atrial appendage occlusion and add all anticoagulation in patients who don't have a contraindication? Maybe this would be the best solution for patients with no bleeding risk. So I think that would be the perspective for me.
Great, thanks a lot. I mean, we've just had another post in the chat. Someone wrote, "Thank you for this great session. I learn a lot." I guess that's the best compliment that one can give a faculty. So I guess that we can now finish the session. It was great to have the audience online. It was great to be here in the faculty with my experienced colleagues from Spain, France, and Germany. I hope that this event I hope that this event will attract more and more patients and doctors to get the future to the direction that we proposed. And from my side, I can only say thanks a lot. Have a nice evening. Goodbye.
Thank you. Bye-bye.
Bye.
Bye-bye.